This program is brought to you in association with First National Bank of Botswana. Most of us grew up knowing that being a doctor, a nurse, or any other medical professional was a revered career path. Parents wanted and maybe still want their children to be medical professionals because that would bring the family some sort of prestige. Nonetheless, this is a career path that has for a long time been deemed financially rewarding, what with the long hours studying and the number of years spent for a single degree. This does not negate that these individuals endure long hours at work caring for patients, where in one room a woman is giving birth to her first child, or having to deal with an erratic patient in the emergency room, or that one patient who came into radiology for a chest x-ray. Theirs could be days that span anything from 8 to 48 hours straight, highly unpredictable and stressful, as the expectation to care for and save lives rests squarely on their shoulders. This evening, we're with Dr. Kiran Bhagat in conversation about the shades of medicine as a career, where we get first-hand insight into the profession and why, with all of its demands, one might want to go into this field.
I think it's the classic answer for most A-level students that we interview is they want to help people. But it's usually more than that. It's usually the influence when you're growing up in childhood. You see somebody, you help somebody, you see somebody in the family who's done medicine or who is a nurse, who is a pharmacist, and you think, I quite like this. I like the idea of biology. I like the idea of helping people. I like the idea of seeing people get better. I like the idea today in the 21st century of technology and how technology interfaces with biology. So there are lots of reasons why, but primarily I think it's one must remember that medicine, or the practice of medicine, is both a science and an art. It's the art of practicing and communicating with your patient, and it's the science of knowing exactly what is wrong with the patient and then how to communicate it. And these are the things we try and teach medical students. So I think it's both. It has its feet in both the sciences as well as the arts, and that sometimes is what appeals to students in their final years of A-level, to say, this is where I'm heading in terms of how I see myself.
When it comes to what the prerequisites of being a medical professional are, gone are the days when all that mattered were good grades. Dr. Bhagat says in today's constantly evolving world, a well-rounded individual is preferred.
I think the prerequisites to going into medicine as a profession is first a commitment to continuing education. There is this misconception even today that once you've finished your degree, you're done. It may occur in the arts, it may occur in law, it may occur in IT and computer fields. But medicine is a continual process. It's continually learning, it's continually upgrading, it's continually attending seminars and writing exams and doing further qualifications, because medicine is a rapidly evolving science, particularly now in 2023. We've been through pandemics, we've been through new vaccines, we've learnt about artificial intelligence. People are talking about ChatGPT, but in terms of the biology of medicine, it's changing very rapidly. So I think the first thing we look for in students coming out of school is not only their grades, but their commitment. Because yes, it's very tough, the demands we make on the subjects they do, and of course one needs to be heavily grounded in the sciences in order to enter medicine. But I think in parts of North America, Canada and Europe, we're now also encouraging those who have done arts at A-level to consider medicine a sort of a hybridized medicine, because we know that certain biological sciences tend to make one nerdy. The biology, the chemistry, the mathematics, the physics, which used to be the substrate, the platform on which we would, before we even talk to you, we would want to have straight A grades in them. And so we know that it takes a certain type of individual to be committed at A-level to get those grades or those numbers to get into university, and it's highly competitive because medicine has a limited number of spaces even at our university, but worldwide, there are spaces that are limited, so everybody's competing, so everybody wants to do well. So by the time we see the students of A-level, they've got their grades, they've got their straight A's or A stars or whatever it is that they're graded by. And so what we look for are other aspects in that student, because if you have 100 A-level students that have all got 4 A's, straight A's, how do you choose 50 of them? You choose based on personality, you choose based on extracurricular. What else have you done? Have you learnt another language? Have you traveled to another part of the country or the region? Have you learnt a musical instrument? Do you have an interest in the arts? Can you draw? Can you write? Can you play football? Are you a sportsman as well? So we try to see if we can ground that individual not just becoming a nerd, but somebody who actually is able to deal with patients. Because we find in medicine that sometimes you do have a highly select percentage of our population, which sometimes tend to be too bookish. They're always down in looking at reading and updating themselves and not communicating. And so one must remember that medicine is an art, and so communication is very important. So we're beginning to understand that we need to make sure that the individual coming into medicine is grounded.
As a highly stressful and significantly demanding profession, what are some emotional and psychological pressures that these individuals deal with, and how are they managed?
That's a very big question, and I think it's a question that I think still looms large, and I call it the shame of medicine, in that both at medical school as well as a junior doctor, in fact even prior to entering medical school, the sort of personality that decides they want to do medicine is always advised, you need to study hard, you need to read lots of books, you need to make sure you don't go out and play, you need to make sure you don't go out to nightclubs, you don't socialize, you don't take too much alcohol, you don't do substance abuse. So it takes a certain personality that commits themselves even at high school as to, I want to become a doctor. And as a result, you gradually withdraw from the rest of society. You become bookish, you make sure your grades are high, you make sure you spend lots of hours behind a book or a computer. You don't enjoy some of the things that your colleagues are enjoying. And there's also a shame in not performing, because you already know from colleagues of yours that are also trying to get into medicine that you need to be in the 98th percentile. You need to make sure that your grades are always A. So there's a shame, if you like, in not passing. There's a shame in admitting that you've not passed something. There's a shame in actually admitting that you even got a B grade. So that shame starts very early, and we see it in medical students as well, that there is also a shame in not admitting they don't know. Often we'll see a medical student and the medical student will have the perception that the attending physician will expect them to have known the entire knowledge of how a particular drug works. And so there's an embarrassment and a lack of ability to say, I don't know. I think there's also a shame in admitting fatigue. As a junior doctor. Junior doctors work very, very long hours at very little pay, sometimes on call for 48 hours at a stretch and are tired in the morning. There's a shame in admitting that you are tired. There's a shame also amongst clinicians to admit that you're ill, because you are there to look after somebody else. So nobody asks the doctor, how are you, doctor? So if a doctor's not well, you hide that. If you don't feel well, you feel dizzy, you've got a running stomach, you have people to attend to. If you are an emergency room doctor, there's no time to ask about your own fever or your own sinuses or your own headache. You have to attend to others. So there's a shame in that as well. There's an adage in medicine that we call see one, do one and teach one. In other words, you will see a doctor performing a particular type of injection, you're expected to do it, and then after you've done it, you're expected to teach it. So there's an assumption that you will know how to do these things very rapidly, and there's a shame in understanding, I don't know how to do these things. So these are aspects of shame in medicine that we're trying to uncover, because it results in enormous trauma later on. There's a trauma and a shame in mental disorders amongst junior doctors and physicians, because the stress of medicine in terms of meeting the standards, making sure you're performing for your patients, making sure you're there for your patients, results in an enormous burden, mental burden. So there's nobody asks the doctor if they are suffering from a mental stress. Doctors also have depression or anxiety organic psychosis. Some doctors may have schizophrenia or bipolar depression. How do you manage those in a doctor? So these are aspects that we are beginning to understand are lacking in our training, and we're trying to imbue in our young medical students.
We live in a world that is characterized by different cultures and beliefs. We asked the good doctor if there are any cultural conflicts that affect medical professionals when doing their jobs.
I think the cultural context in which we practice, certainly in Botswana and on our continent, has to be taken into consideration. You know, I remember very well some of my junior training occurred in South Africa during the apartheid era, and I remember first going into South Africa and a white patient saying that they don't want this black doctor to be examining them. So the cultural context in which you're suddenly faced with this sort of issue surprises one occasionally. Or you will see a patient whom you know could be your grandmother, and you know that she's taking traditional medicines. You know that, and the reason why she's taking traditional medicines. And you know the junior doctor's not asked Mosadi Moholo, what is it that you're taking? Whether it's snuff or whether it's, you know, some sort of concoction that the traditional doctor has given. Because we all know that certain cultures have certain traditions in terms of take this for flu, take this for congestion, take this to help you sleep, you know, and it's very rare the junior doctor will ask, and it's very rare that the patient will volunteer that this is what they're taking. So I think it's important to understand the cultural context in which you are treating that patient. Some patients may be unwilling to take 5 different drugs because they've been told that the more drugs you take, the more at risk of overdose. Some patients may have the idea they're going to become addicted to a painkiller, so they won't take a painkiller. Some patients will try and mix their traditional herbs with the prescription that you're taking. And unless you understand the cultural context into which they're going back home into, some of the medicine that you're trying to practice will not work simply because it doesn't gel with the cultural context in which they're going to see. Because inevitably a patient, particularly an elderly patient, will go home and perhaps visit a traditional doctor or be visited by somebody who has advised them to say, go and see a traditional doctor. We've all seen patients coming to hospital with this diklabi where you can see they've seen a traditional doctor, but they are reluctant to talk about what happened between them and the traditional doctor.
In medicine, we have learnt that there is such a thing called over-treatment. What is it?
I think over-treatment of patients is what we call futility medicine, and it's a medicine that is beginning to emerge as a result of technology. In very simple context, an example might be somebody who is at the end of life because of severe cancer. Say, for example, they are 70 years plus and they are riddled with cancer, but a new medicine comes into the department which is able to be given for this particular type of cancer. One has to understand the context in which one's giving novel medicines or new technology or new imaging or new diagnostics, as to ask oneself, to what benefit is this patient going to derive this new medicine or this new technology? For example, this 70-year-old with multiple breast cancer spread may have another 4 weeks extra with this medicine. And you have to ask yourself, is that 4 weeks worth the pain of the medicine, the side effects of the medicine, the ability of the patient to stay in hospital for another 4 weeks rather than go home and be with their family? So increasingly we need to teach our medical students that there comes a point in time where you say that the patient needs to leave end of life in a dignified manner, you know, in an honorable manner, and not for the doctors to become cowboyish, because the technology exists, the imaging exists. You know, what is the value of doing another CT scan or MRI scan when we know that the end of life is soon? What is the point of resuscitating a patient that really is already suffering in terms of their biology, in terms of their pain, in terms of their lack of ability to communicate? So the context in which you are practicing that medicine, the age, the culture, the multiple morbidities, the other conditions that they have, need to come to bear, because increasingly, unfortunately, medicine is what we call siloed, where a patient will see an ear, nose and throat doctor or an allergy specialist for their sinuses, and see a blood pressure specialist for their blood pressure, and see a headache specialist for their headaches, rather than somebody who deals with all of it. And so it's important to understand these aspects when one's training a doctor as to appreciate how much do you do and when do you say enough is enough? When do you ask a patient, if you collapse, should I resuscitate you? You know, it's something, you know, in North America and Europe, they have what's called a code blue, where a blue light means you all need to rush to that particular patient who's collapsed. But there may also be, you have asked the patient and you have what's called DNR, which means do not resuscitate. The patient has agreed that if I collapse, I do not want to be resuscitated, or if I collapse, I don't want to be on a ventilator. So these are things we need to ask our young doctors to ask the patient, particularly those that are towards the end of their life, that if this happens, do you want these things? Because there's no good rushing, you know, hell and high water to resuscitate a patient that really doesn't want to live much longer.
With everyone having their own different experiences at various health centers, do doctors infantilize patients?
Oh, absolutely. I think, you know, one has to understand that and we've all been at some point a patient, if you like, whether it's in an outpatient in a doctor's room or in a hospital. You know, when you go into hospital, just think about it. You undress, you are put into a gown, you are asked to put your belongings into a locker. You are told when to eat, you are told what to eat, you are told when to go to the toilet, you are told to empty the contents of your bowel or bladder into a particular container because you need it, the doctor needs it to be analyzed. The nurse will come every 4 hours and wake you up to check your blood pressure and your temperature. There are alarms going on all the time, so you can't sleep very well. You know, you're woken up at 2 in the morning because the nurse wants to check your blood pressure. So you lose all respect, if you like, in terms of your dignity when you go into hospital, because you're put into the situation where you're told what to do. And it's a shock for most doctors who become patients to understand, goodness me, this is what it's like. This is how life is on the other side. I mean, I remember the first time I was admitted in a hospital that didn't know me, and you know, I was told the doctor will be with you shortly, and I had to think for a while, you know, which doctor? I am a doctor, you know, and to be given to receive instructions is also odd for a doctor. So we do tend to infantilize and make children of our patients when they're in hospital, because they lose all autonomy.
It is obvious that medical professionals sustain and save lives with everything they have, but it is not always good news, especially for the patients and their families. How do they then learn to break bad news to those they have cared for?
Again, it's an issue of communication. How breaking bad news to a patient is undertaken is still very poorly done, in my opinion. Where one needs to understand how to approach the idea of death, for example, how to approach the idea that a patient has newly diagnosed cancer, how to break news that the kidneys are failing or the liver is failing, or in my situation we've done a scan of the heart and we know the patient has heart failure. We know that the life expectancy of somebody who has heart failure is 50% die in 5 years. How do you break that news? And these are things we are yet to teach our medical students, you know. Whom do you talk to? If the patient has had a stroke and is not able to understand, who do you talk to as the next of kin? How do you talk to them? How do you talk about the rest of the patient's life as to how they manage it? If the patient is about to die, how do you approach the family to say, you know, you need to gather around and you need to maybe call a priest in? These are things that are not done well in our situation, because I think we're at the early ends of teaching this field of medicine called palliative care medicine, which is care of somebody who is dying from whatever it is, whether it's cancer or multiple diseases such as diabetes or stroke. Or heart failure or kidney failure. So I think the idea of communicating with that has to be often, you know, it's a very common situation where the nurse knows how to deal with that situation better than a doctor. Very often I have seen in my lifetime a doctor doing a round in the hospital, and when the doctor leaves, the patient asks the nurse, what did the doctor say? Because the doctor, one has to understand that when you go into medical school, you're learning an entirely new vocabulary. I remember telling students when they come for the first lesson of their entire life in medical school, that if you come in with a vocabulary of 20,000 words, by the time you leave medicine, that vocabulary will be 3 times more. Because you're learning a new language. You know, we learn languages from Greek and Latin that you will not understand. You know, we speak certain language in Latin and in Greek. So by the time a medical student leaves the hospital or the study of medicine, they are speaking an entirely different language which the public can't understand. So these are things that medical students need to understand, that they cannot jargonize to a patient. And it often happens, I see medical students telling a patient, oh, well, you have renal failure and we're going to dialyze you. The patient doesn't know what renal failure is. They don't know what dialysis is. I have patients who don't even know what hypertension is. So you need to make sure that you simplify the language so the patient understands what you're saying, and not for the patient to say to the nurse, what did the doctor say?
In the event of a loss of life, Dr. Bhagat says doctors and other medical professionals have learned to separate themselves from their emotions to be able to cope.
One of the issues that we have is as doctors, you learn to train yourself to separate yourself from your emotions. You learn to deal with death as something that happens, just as much as you learn to see the sight of blood or the sight of a decaying part of the body where the body is becoming gangrenous. You learn to recognize the smell of somebody who's about to die. You learn to recognize the smell of somebody whose part organ is beginning to decay and to become gangrenous. You also learn at that same point to deal with excrement, you know, the feces, or somebody who's incontinent. You learn to accept the smell. You learn to accept the condition that somebody is in by creating a barrier. You create a mask because you know that if you become emotionally attached to a patient, which is why doctors are not generally allowed to treat their own family, because that emotional attachment blurs the practical, real reasons and your emotions become imbued in it. So as doctors, we learn to train to hold our emotions, and the issue of death becomes something that you need to learn empathy and compassion, but at the same time you need to distance yourself lest you become emotionally involved in the death of that particular patient. And it's a very difficult process to understand because, you know, doctors have pets that die and they cry. Doctors have mothers and sisters and brothers that die and they cry. But it is not often you will see a doctor who will cry at the death of one of their patients, because they've learned to accept the mask that they need to wear when they walk into a hospital.
This program was brought to you in association with First National Bank of Botswana.
FNB, how can we help you?